Yes, my name is John Mann. I'm a professor of translational neuroscience at Columbia University.
Hello, this is Dr. Lorenzo Norris, Editor-in-Chief of MD Edge Psychiatry. Welcome to today's Psychcast. We're privileged to have Dr. Mann with us here today, and we're looking forward to having a really good discussion here in regards to suicide and getting a little bit of Dr. Mann's perspective on various aspects of suicide in the country and really how this applies to clinicians and patients alike. So Dr. Mann, thank you and welcome to the Psychcast.
Thank you, it's a pleasure to be here.
So Dr. Mann, suicide, it is obviously a preeminent health concern across the country. Can you tell us a little bit about, in terms of your perspective, in terms of suicide rates in the United States and what it is that we are seeing and how we can really interpret this data?
Well, actually the data are pretty alarming, frankly. So if you look at roughly the last 17 or 18 years, since the year 2000, we have data through 2017 from the CDC. The suicide rate in the US has been going up steadily every year. And this might be regarded as something that's affecting the rest of the world, if you didn't know that the rest of the world, in fact, has been experiencing largely a decrease in suicide rates over that time. So we've slipped from being 30-something in the world in terms of suicide rates down to 70-something in the world, which is out of 100, which is really a huge slide. Alarming slide for the world's richest country. And we think we've improved the healthcare delivery system a lot with the Affordable Care Act and so on and so forth, and we have made some progress. So the question is, why are suicide rates continuing to rise? There are probably many factors. Some of them might include the recession of 2008, but of course suicide rates began rising in 2000. Some might include things like the heroin epidemic that we're now experiencing, but that's only the last few years. So now we have, and now the economy is better than ever. So what's really going on? A clue to the answer comes from the CDC study that looked at people who died by suicide and examined which ones had psychiatric illnesses and were they being treated at the time of death. So in the US, our most recent numbers show that only about 22%, about a fifth of patients with a psychiatric illness who die by suicide die while they're being treated. So that most of them are dying untreated. And we already know from many other studies that 90% of suicides occur in people with a psychiatric illness. So now we have the even more disturbing discovery that most suicides are occurring in an untreated psychiatric illness. So it's not as if people are treating them and doing their best trying to get better or being treated, and the doctors are trying to get them better. They're not even being treated. So the question is, what's going wrong?
Yeah, what is going wrong? So I want to make sure I heard this, all right. Now, roughly a fifth of, in terms of when we're thinking about suicide, there are many people who are dying who are untreated. Only 22% have actually seen a psychiatrist or are treated, if I heard you correctly in regards to that.
That's correct.
All right. Now, what, if I can ask a question, has there been over the years, if we know this, has there been a percentage change in the number of people treated versus untreated? Did something occur where we're experiencing, for lack of a better word, more deaths in those that have been untreated by a psychiatrist? Because as you mentioned, the suicide rate has been going up for years right now, but I don't know if the number of treated versus untreated, if that ratio has actually changed in that subsequent time frame.
So we're not sure of the answer to your question, but there are some possible answers. One of them is that, as far as we can tell, we have, many years ago, we were not doing a very good job of treating people who died by suicide, who had psychiatric illnesses. And the latest data just shows us that we haven't improved much. So little improvement. But then the question is, why is the rate going up? And we even know that suicide attempt rates in young people showing up in emergency rooms and so on and so forth are also going up. So something's happening. Well, one of the things that's happening is that depression is starting, the illness, depression, is starting at an earlier and earlier age. And then we know that people who are at risk for suicide are not just suffering from a depression, they're suffering from they also have a predisposition to respond to depression by suicidal behavior. And that predisposition is there before they ever have the illness.
Okay.
So once the illness appears, then suicide rates begin happening in our population. So mood disorders generally start in teenagers, on average. But years ago, they used to start in people in their 20s.
Right.
And then prior to that, in their 30s, and prior to that, in their 40s. So the more recently you're born, the earlier the depressions are going to be starting. And that earlier onset of depression begins to uncover these suicidal people, but with people with suicide potential. And so part of the reason that the rate may be going up is that more of the population is now at risk because the illness is starting earlier.
Okay. All right, that really makes me think, because just as a psychiatrist, and even when I talk to my colleagues, I don't know how other people in the audience or the listeners would think about this. I would say the most common question that I get asked is in regards to child and adolescent psychiatry, or how do you deal with depression in either a young adult or, if you will, someone in middle school or going into high school. And that to me is something that people are constantly thinking about. Now, given my career, I was born in the 70s, so I don't know exactly if those conversations have changed over the years, but I do think that Dr. Mann, when you spoke about the disease and the depression starting earlier, from a clinical level and just from a personal level, when I'm kind of on the street, so to speak, we do get that feel. The other thing that I've always been curious about in some of my colleagues is the effect of our current society in terms of social media. And we're connected, but in certain ways we're disconnected. And maybe there's been a loss, if you will, of some type of protective effect of community. I don't know the evidence base behind that, nor do I pretend to, but I do notice that we have smartphones, we have all of these things, but still one of the chief complaints that I hear about is loneliness, isolation, lack of community. So when you said depression starting earlier, as well as a tendency to respond to depression with suicidal, if you will, behaviors or tendencies, those are the kind of things that I start to think about. On that frame of suicide and the individual, I was wondering if you could talk to us a bit about suicide at the clinician level, because, again, going back to your earlier point about treated versus untreated, what, as clinicians, do we need to be thinking about when a patient comes into our office, given the alarming rates and the increase of suicide?
So there are a couple of different things. First of all, we have to remember that the rate of people seeing their doctor before a suicide attempt is twice as great for a non-psychiatrist as it is for a psychiatrist. Okay. So while about 20% of people will see their mental health professional, that might be a psychiatrist, psychologist, social worker, within 30 days of a suicide, 40%, twice as many, see their doctor, their non-psychiatrist doctor. That's generally their internist, their OBGYN, or the like, GP. Right. So that's really critical. That tells you a couple of different things. There was a study that was done on soldiers who died by suicide, looking at their healthcare utilization compared to matched soldier buddies. The soldiers who died by suicide went along to see the doctor in the military for help and had the same number of lab tests as their controls, who had nothing to do with psychiatry illness and no suicide, etc. But they had the same number of lab tests. But when you looked at the results of the lab tests were largely negative for the suicides. So what we learned from that is that they're probably going along to their doctor with somatic complaints. And the doctor, and the whole conversation never gets out of that domain. The doctor runs some tests, tells them everything, the tests seem negative, why don't you get some more exercise or live more healthy, eat more healthy food or something like that, and then it sends them away. There's no recognition that those somatic complaints are actually part of a mood disorder, for example, which is the case in 60% of the people who have these psychiatric illnesses. And therefore there's no progression to the treatment of that. So the patient basically leaves now having been told they're really healthy, pull your socks up. or you need a lifestyle change, which of course is not the standard of care for the management of a mood disorder. And if they're also suicidal, so we think that conversation may be the sort of thing that goes on some of the time and contributes to this lack of awareness or lack of diagnosis and treatment, which is why several studies in different countries have now shown that if you take GPs and just train GPs in nothing else but how to diagnose and recognize depression better and treat it better, you lower the suicide rate. You also lower time off work and a number of hospitalizations and so on, because you're making the population healthier. You're actually recognizing what's wrong and treating it. So, of course, depression is one of the leading causes of disability worldwide. So if you focus on fixing that. But the suicide is one consequence of untreated depression. So one of the things we need to do is to do a better job ourselves of diagnosing and treating depression. Remember that the better you treat the depression, the safer the patient. If you get them half better, you kind of reduce the risk by half. But if you get them all better, then you reduce all the risk. And that lesson hasn't been fully learned in psychiatry, but it certainly hasn't been learned in internal medicine and general practice. So there's a lot we can do.
No, there's absolutely a lot. And just to briefly follow up on that, I thought that's such a powerful observation because in my role, I'm also a dean, and in terms of involved in training of higher education, in terms of residents, medical students, what are we doing in terms of that training, in terms of recognizing depression? But I think one of the most powerful things that you said is the negative lab results and the patient's complaints, and then we're like, you're okay and you can leave. But if you're not, one of my colleagues, Dean Haywood, as well as others, if you don't have a spirit of curiosity, if you don't have the training, and you don't actually say, wait a minute, or better yet, if you don't trust that the patient is coming to you for a very real reason, then you stop then, and that in and of itself, I think, can be absolutely paradigm shifting, as you already spoke about in terms of the studies. Now, Dr. Mann, we've talked about things at the clinician level. I was wondering if you could also comment on, if you will, again, this fact that people dying by suicide are seeking help. The majority of folks that are dying by suicide, they are going to a GP, they're going to their OB-GYN, they're going to a psychiatrist. The majority of people are going to, as you said, either a primary care clinician. What, in addition to, in terms of recognizing depression, can we do maybe differently in terms of acknowledging that the majority of people that die by suicide are seeking help at some point in time from a health professional?
Well, we need to have a shift in our approach to education. A bit like the response to the heroin epidemic. And the prescription of oxycodone and these types of analgesics. What we did was we required every physician in the country to undergo some training to become more sophisticated about the recognition of pain and how to manage pain and alternative approaches and how these drugs work and so on and so forth, and use of naloxone and all kinds of things. So we need something like this for suicide prevention. 17 years of a continual rise in suicide deaths. There's been, that amounts to over 33% increase. That's a huge thing. And this is the second leading cause of death in people between the ages of 15 and 34 in this country. So it's really striking at the core of young people in a terrible way. Second leading cause of death.
I think it's incredibly striking. And when that data came out, I questioned, and why didn't the world and the United States just stop? I mean, if we had a 33% rise in the deaths of breast cancer, as an example, and part of what I do is psycho-oncology, I think everybody would just stop. Frontline news for weeks. But with suicide, people are like, okay. So, Dr. Mann, when you were speaking, what I do think about in terms of when you say we have to have a fundamentally different approach, and I actually think that fundamental approach in terms of our training I think there's got to be many people in the conversation, whether it's the AAMC, residency directors, hospitals, because you are going to require a fundamental shift in terms of how we understand mental health conditions. And again, as you brought up, the majority of people are not seeing psychiatrists. We know we have a psychiatric shortage, so I would also argue that more psychiatrists in and of itself is not going to be the solution. We have to have, if you will, as you were really talking about, a multifaceted approach, because this can be done and this can be prevented, but only if we really understand what is going on and we are willing to invest the time, effort, resources, and energy in the education of clinicians from various areas. Dr. Mann, thank you so very much for speaking with us. I wanted to, if you have any last thoughts for us in regards to suicide, the suicide rates, and how we as clinicians can be of better service to our patients and our communities.
Well, I was taken by your phrase, the spirit of curiosity.
Yes.
I think this is what we need as doctors.
Yes.
We have to get past just doing things exactly the same way over and over and over. We need to learn, retool, upgrade, and increase our sensitivity. We have very little time with each patient, but we need to be aware that depression is going to be the leading cause of death, of disability worldwide. Of all illnesses. So this is a job for all types of physicians.
Yes.
Every physician needs to be able to be competent at recognizing depression in all its different guises that it presents to them.
Absolutely.
And then learn how to treat it properly. We expect every doctor to be able to treat basically hypertension, hyperlipidemias, et cetera, and they all need to know how to treat depression more effectively.
Then most certainly, and we are all trained in CPR, some of us in ACLS. I would also use that also, that you need this, and it's got to be done just clearly on that level where it is universal. I mean, again, this is beyond specialty, this is physician, and this is how we can best serve our patients. So Dr. Mann, I want to thank you for really illuminating a number of things in regards to suicide, and I hope that our listeners listen very closely, and I hope that decision makers and policy makers and those in leadership positions, maybe you're listening to this Psychcast and give us, start to think about how we can actually have a bit of this paradigm shift. Dr. Mann, thank you so much, sir.
Sure, thank you.